join, we can see how to proceed.
Okay, well, good morning, good afternoon, good evening, everyone, and thank you very much for making the time to be with us at this introductory meeting for Community of Practice, Key Population Programming Community of Practice. It's a real honor to be hosting this as the GPC Secretariat. We are supported by Genesis Analytics, and first, let me get back to you, Kerry, on some housekeeping instructions, how the session is going to be run.
Thank you so much, Paula. Colleagues, for today's session, we have set this up as a Zoom webinar. What that means is that we will be primarily engaging through the question and answer and chat function. And there is some limited ability to unmute yourselves as attendees. That's just to try and manage the size of the audience and guide the speakers as they respond to questions. This webinar will be taking place primarily in English, but please do go to the bottom of your screens and there will be real-time French, Portuguese, Russian, and Spanish interpretation. If you would like to listen to the meeting in English, please also select the English channel for your selection. We will try as best as possible to keep to time. This meeting is 90 minutes in duration, and we really welcome participation through the chat function. Paula, I think that's primarily what I wish to share as housekeeping. Thank you.
Thank you, Kerry. And I have the pleasure to invite Dr. Shannon Hayder, who's the Deputy Executive Director for Programs at Unaids in Geneva, to open the meeting.
Oh, thank you, Paula. It is a privilege to be here with all of you. And I'd like to welcome all of the participants here today to the launch of the Global HIV Prevention Coalition's Community of Practice on Key Populations. This is a really important, I think, new venture together, and we're so happy that everybody's here together with us. And in particular, I'd like to welcome the country government focal points for key populations and HIV prevention, the key population community-led organizations at global, regional, and country levels, colleagues from our international partners who support key population responses, and colleagues throughout the UN family at global, regional, and country levels. It's going to take all of us working together to really develop a community of practice that's going to make a difference. And we've certainly all gone through a very challenging 15-month period, and we're excited that with all the work that you are all doing, you took the time to join us to launch this event today. As many of you know, earlier this year, the Unaids board adopted the new Global HIV Strategy 2021 to 2026, and the theme of that is End Inequalities, End AIDS. It has a strong focus on key populations across all dimensions of services, rights, societal enablers, and community-led responses. And it includes ambitious new targets that have been set for the AIDS response, including 95, 95, 95 targets for treatment. And importantly, those 95s, it's not just that they're going from 90 to 95. The big importance is it's 95 for each affected subpopulation, so that we don't lose highly affected communities in the national averages or global averages. 95% of people at risk accessing combination prevention, and some new 10-10-10 targets for addressing structural barriers in the HIV response. And as mentioned, targets are specific to each subpopulation, including the 5 key populations. And this is, I think, not such a nuance, but maybe a new message that we think is very important to hit home, that it's not sufficient to reach these targets overall as an average. We really need to reach these targets for each and every key population. Globally, of course, we have not reached HIV treatment, preventions, and rights-related targets for key populations, and prevention with key populations has perhaps fallen further behind the rest of the response, because some countries are making good progress and other countries actually have growing epidemics. There has overall been no substantial reduction in new HIV infections among key populations globally since 2010. But again, this happened at a time when several countries with HIV epidemics that affect key populations have shown that success is possible. In Cambodia, in Thailand, in Vietnam, new HIV infections have declined by more than 60% since 2010. In Portugal and Estonia, new HIV diagnosis among people who inject drugs declined by more than 90% in just over a decade. So progress is really possible. And these successes happened in a context of scaled prevention and treatment with key populations, in community engagement and community leadership, and with an improved policy environment. So the tasks ahead of us to achieve global targets in all these areas are by no means easy. There is no single sector that can achieve these results on their own. The UN can't do it alone. Governments alone cannot do it. Communities and implementers alone don't have the resources to do it. And that's why we believe that we need to all come together to build country-led and community-led responses. So the community of practice on key populations of the Global Prevention Coalition, we hope will be a platform for bringing together these different players in different parts of the world to share and learn. A platform for implementing the new global AIDS strategy as it pertains to prevention, and a platform for addressing the specific needs of key populations in relationship to prevention, in HIV testing and treatment, and rights and removal of structural barriers. So I do hope, not just today, but as we move forward, you can all actively contribute to the discussions and exchanges, and over these upcoming sessions planned throughout 2021, help make this a strong and practical partnership that brings change on all levels. Every single region in the world has an HIV epidemic that involves key populations. So the insights might be distinct, the successes might be unique, but I think the lessons and the problem solving and what we gain by all coming together is going to be extremely powerful. So thank you for letting me be here to welcome you and launch today, and I will turn it back over to Paula.
Thank you, Shannon. And to give opening remarks from the perspective of communities, I'd like to invite Ruth Morgan-Thomas. Ruth is the Global Coordinator of the Global Network of Sex Work Projects. Welcome, Ruth.
Thank you, Paula, and thank you for the invitation to join this opening. I'm going to give a little bit more detail about why it's important that we actually look at key populations as priorities. So over the 3 years that I've been a member of the Global Prevention Coalition Working Group, I've seen new infections amongst gay men and other men who have sex with men, people in prisons and other closed settings, people who use drugs, sex workers of all genders, and transgender people. The new infections continue to rise until they now account for 62% of new HIV infections globally. But there are significant differences between the regions. So 99% of new infections are among key populations in Eastern Europe and Central Asia, 98% in Asia and the Pacific, 97% in the Middle East and North Africa, 96% in Western and Central Europe and North America, 77% in Latin America, 69% in Western and Central Africa, 60% in the Caribbean, and 28% in East and Southern Africa. But key populations in every country around the world carry a disproportionate burden of HIV, and yet our population sizes are relatively small. We're at greatly elevated risk of HIV infection when compared to the remainder of the populations in all regions and in all epidemic settings. Gay men and other men who have sex with men are 22 times higher risk of HIV acquisition, people who inject drugs are 22 times at higher risk of HIV acquisition. Female sex workers are 21 times higher risk of HIV acquisition. Transgender women, 12 times higher risk of HIV acquisition. And people in prisons and other closed settings have 6 times higher prevalence than the remaining population. So we have much to do in this community of practice. If we are to succeed, it's critical that key populations are considered experts, and key population-led organisations and networks are adequately resourced to play a central role in the HIV prevention response. I look forward to working with you all over the coming years as we deal with this epidemic within our communities. Thank you. Back to you, Paula.
Paula, are you there?
It's Ruth here, sorry. So, Ruth, the second Ruth, sorry, colleagues. So to give opening remarks from the perspective of government program, I'd like to invite Ruth Laibon-Masha, who's the Chief Executive Officer of the National AIDS Control Council of Kenya. And Ruth also chairs the other community of practice that the Global HIV Prevention Coalition supports, which is a community of practice of National AIDS Council directors. Welcome, Ruth.
Paula, I'm afraid Ruth hasn't been able to join yet. Perhaps we can just move to the next item, and if she joins, we could allow her in a bit later.
Okay, well, in that case, we can move into the objectives of this session. And to give that presentation, I'd like to invite Innocent Modiatsile, who's a senior advisor on HIV prevention in UNFPA in Eastern and Southern Africa. Welcome, Innocent.
Thank you very much, Paula. My presentation is going to be on the objectives of why we are meeting today. Then basically I'll cover four things, just to give the context of the GPC and discuss the objectives of community of practice, and also deal with the objectives of this particular core. Most of you may be aware that in October 2017, 50 like-minded organizations, which included UN co-sponsors, civil society, public and private sector funding partners, and UN member states, came together in Geneva and formed the Global HIV Prevention Coalition, which was convened by Unaids and UNFPA. The coalition basically was established to address HIV prevention agenda, which hitherto was lagging behind. And as the Deputy Executive Director indicated, the progress is still not to the level that is satisfactory. The coalition focuses on 28 countries which contribute the most in terms of infections in the world. And it is supported by the Secretariat that is based in Geneva. So the Secretariat, among other things, has actually recommended the establishment of community of practices. We have several, including the ones on condom. And today we are focusing specifically on the one that is around key population. The overall goal of the community of practice for key population is really to build a community constituted by key population program people, policymakers, implementers, donors, and key population networks across different countries. Specifically, it is intended to address three specific issues. One, to create a safe space for frank discussion on how to accelerate programs. Two, to facilitate peer-to-peer or country-to-country exchange of experiences in program development, implementation, monitoring, evaluation, and community engagement. And also, we view this as a platform to receive critical updates on global policy, latest guidance, implementation tools, and financing opportunities. In terms of this meeting, its focus is two-pronged. First, it's really to introduce the meeting participants to the objectives of the community of practice. And secondly, to familiarize the participants to the current context of key population programming. Lastly, Chairperson, I want to indicate that the meeting will be able to address also other important issues, such as an update on the new global targets, and also to share some recommendations from the deep dive sessions that have been undertaken by the GPC, and also to share some of the tools that are available for key population programming. It is also important to note that the UN agencies are all committed to the SDG principle of leaving no one behind. And so we see this as an opportunity also to work as the UN to actually support those that are left behind in the context of HIV. And lastly, it's important to note that this is complementary to other initiatives that are in place, such as the initiatives on stigma and discrimination, and many other initiatives that are intended to address issues of discrimination and stigma, and also of populations left behind. I thank you. Over.
I'm sorry, Isaac. Thank you, Innocent. I'm still muted. Kerry, are we taking questions now, or do we just move on to the next presentation and do this later?
Paula, I think our recommendation is that we continue with a few presentations so that we can have a discussion on many items at the same time. And maybe just a reminder to colleagues to please put questions in the question and answer box so we can get an indication on discussion items.
Thank you. Thank you for that. So could we now move on to Keith Sabin? Keith is a colleague from the Strategic Informations Department in Unaids Geneva, and he will give us an overview on the global 2025 targets, including some reflections on the current status of the targets and resource needs to deliver on the new global AIDS strategy. Keith, the floor is yours.
Thank you, Paula. May I have the next slide? So we've made some attempts to look at changing HIV incidence among the various key populations. And this is what we've seen since 2010. And essentially, if the blue boxes fall within the yellow lines, the yellow hashed marks, we're seeing no change. So basically, among female sex workers, people who inject drugs, and transgender women, we've seen no progress whatsoever. And among gay men and other men who have sex with men, we've actually seen some regression. The HIV incidence is going in the wrong direction. So I think whatever we can do is critically important in terms of expanding the reaction and the AIDS response for these communities. And next slide, please. These are the distributions by new infections. Ruth has already cited a number of these numbers, so I'm just going to show these. I think most people have seen them by now, and I will continue on to the next slide, please. This is just to give a sense of what we do know about HIV prevalence among the various key populations in the UNAIDS regions of Eastern and Southern Africa and West and Central Africa. As a comparator, we have in the text box HIV prevalence among adults aged 15 to 49, which in East and Southern Africa was 6.7% in 2019. And you can see the mean prevalence, which is the marked by the X within these boxes. It's fairly faint in this slide. It's substantially higher than 6.7%. And we see the same in West and Central Africa. So again, these are just indicative that there's still much to do, particularly in Sub-Saharan Africa regions, where I think we've not seen enough work in the AIDS response focused on responding to the needs of key populations, communities. Next slide, please. We do see reasonable uptake globally of HIV testing and knowledge of HIV status among the different key population communities. It varies widely by region, and this is a global figure. But I would also like to point out that we have one issue in that many of these measurements are occurring where programs are already existing. So it may be overestimating the actual HIV testing awareness in these communities. Next slide, please. These are some of the results that are reported to UNAIDS in terms of whether or not different communities have received at least 2 prevention services in a 3-month period of time. So for men who inject drugs, we see fairly high coverage in Cambodia, but much lower coverage as we go down this list of countries. Next slide, please. All right, this just skipped a number of slides, but I'll just speak. There we go. These are similar graphics for female sex workers and men who have sex with men, and men who inject drugs, and transgender women as well. So, and now we're jumping around. So next slide. All right, let's stop there. This is just to give a sense of where we are in terms of needle and syringe coverage in the number of needles and syringes distributed per person per year. The global target has been greater than 200, and there are a handful of countries in that list. Cambodia has very few people who inject drugs, but they do have a somewhat successful needle and syringe program. The majority of countries have medium and lower, much lower coverage reported to us. And then when we look at the country spending on prevention interventions, we don't have this data for very many countries. But here we can see that in Myanmar, where the epidemic is primarily among people in key populations, 76% of the budget is not going towards prevention among key populations, although appropriately more than half of what is going for people who inject drugs. Next slide, please. Now, looking at the targets real quickly, we're trying to stress that there are a number of choices that community members can make. So we would consider any event that is protected, regardless of the method of protection from HIV transmission, is a successful process and outcome. So whether someone is being protected by consistent and correct condom use, or PrEP use, or a suppressed viral load, or for that matter, condoms and PrEP, and then needles and syringes for people who inject, these are all valid choices, important choices that will protect people. Next slide, please. And so we move on to the targets. That sense of choice makes setting targets rather difficult, but the way that UNAIDS has undertaken in setting up the global strategy to look at targets is to create a set of strata by risk. And so we have a low and moderate risk column and a high risk column, and then a very high risk column, which is established through a different criteria. And so in this case, we're looking at the strata to get a sense of what those strata look like, and how they'll be operationalized is a much longer conversation that is not for today with me. Yeah, and so here are the detailed targets for HIV prevention. We want to see maximum condom use and or other methods taken up, but we're establishing condom use at a very high level of 95%. Among sex workers, condom use at last sex with a client should be above 90%. Prisoners, where it's relevant, should be above 90%. And then we're trying to see PrEP use, particularly in the highest risk groups among these communities, to increase from, in many cases, negligible PrEP use to high or very high PrEP use. And this goes on. I want to touch real quickly on social enablers, which are highlighted in the purple boxes. These are now being referred to as the 10-10-10 targets for removing social and legal impediments towards creating an enabling environment. So we would like to see fewer than 10% of countries with punitive legal and policy environments. We want to see fewer than 10% of people living with HIV and key populations reporting the experience of stigma and discrimination, and then fewer than 10% of women and girls living with HIV and key populations experiencing gender inequalities and violence. Next slide, please. We believe that if we can achieve these targets in creating a socially enabling environment, that we will alter the epidemic further in our model projections to follow these blue lines, these blue hashed lines past 2020, and see an even steeper, more rapid decline in both HIV infections, new infections, and in AIDS-related deaths. Next slide, and this is the last slide. In our analysis, in the UNAIDS analysis of what it will cost to achieve these targets, we're looking at roughly almost $10 billion to be required just to meet the HIV prevention targets among the different key populations groups. And that's reflected in this, the rainbow boxes in the right-hand column, what we will need by 2025. And with that, I'll close and turn it back to the moderator.
Thank you, Keith. Colleagues, as we said, we would save some time at the end for the discussion and any question that you may have. So please hold on to your questions, put them in the chat. Kerry's watching that as we progress. I'd like to look back to Ruth Liborn-Masher, who has now joined the session. Ruth, as I said before, is the Chief Executive Officer of the National AIDS Control Council in Kenya. And I would like to invite her to give some remarks on from the perspective of National AIDS Control Council and National AIDS Control Programs. Ruth, the floor is yours. Ruth, you're muted. Are you on the call?
Hi, Paula. This is Karongare. Ruth Masha is so held up in a high-level meeting. She's not able to join us today.
Hi, Carol. Are you able to give opening remarks for Ruth, or should we just proceed?
Hello, Paula. I don't know whether you can hear me. Paula, you can hear me?
Yes, Carol, we can hear you.
Yes, Dr. Masha is currently held up in another high-level meeting, and she has just asked me to step in, and she'll try to join the 5 p.m. meeting. Sorry about that.
Thank you,
Apologies.
Carol. Thank you, Carol. Would you like to give some remarks on behalf of Ruth, or should we just proceed?
You can give guidance because the meeting has already begun. Maybe making remarks would be going backwards. And there's also a lot of background noise. I don't know whether it's from where I sit or.
Okay, Carol. Thank you for joining us. We will proceed. We have just heard from the Strategic Information Department on an overview of the global targets. And our next presentation is going to be by Judy Chang. Judy is the Executive Director of the International Network of People Who Use Drugs. And Judy is going to summarize preliminary outputs and recommendations from a series of deep dive sessions that the Global Prevention Working Group conducted during 2020 and the early part of 2021. So Judy, thank you for being here. And if you would like to proceed with your presentation, please.
So difficult to hear, but I'll read the slides.
Okay, Carol.
Thanks, Paula. Yes, I'll be presenting the recommendations, a summary of the recommendations from the Global HIV Prevention Working Group's deep dive series on key populations. And thanks for the Global HIV Prevention Working Group for preparing the slides as well. So just to give a very short background, as Innocent mentioned, the HIV Prevention Coalition was launched in 2017. There was a set of scorecards also developed to measure progress, but we know that insufficient headway was made on key population programming. Many countries did not even have population size estimates for key populations and did not sufficiently resource design, implement, or monitor. And I think, as we all know on this call, that headway on HIV prevention cannot be made without a dedicated focus. So there was a decision made by the Global HIV Prevention Group to strengthen its focus on key populations, and therefore there was a series of deep dive sessions held across 2020 to 2021. So the first one was on making the funding case. Second session was reviewing combination prevention packages. Third was planning for sustainable response. And fourth was focused on adolescent and young key populations. So the recommendations and action points from the deep dives, it's hoped that these can then inform the community of practice. So next slide. So the recommendations from the first session, the first three recommendations mainly related to the Global Fund. They are to build capacities among key population communities to engage in Global Fund processes and to make sure that funds to key population networks are allocated to enable meaningful engagement in global fund and other decision-making processes. And the third, to champion key population investments and involvement of key population-led organizations in CCMs. So we know in some ways this is, being done through some mechanisms such as the CRG, the Global Fund Community Rights and Gender Strategic Initiative, where global key population-led networks are providing small grants and building capacity. But of course, the scale of need outpaces the available resources. We know the unique strengths of peer-to-peer technical assistance, and also in grant disbursement and allocation, that peer-led networks are able to reduce administrative burdens and requirements and know where the money needs to go. So just to say as well, with the recommendations in the parentheses at the end are just the key actors that would be involved or taking a leadership role within making sure the recommendations and action points are implemented. So next slide. Oh, I think I was still summarizing. Yeah, thank you. So just to quickly go through this, again, to make sure funds are earmarked for key population programs. We know, for example, in Global Fund grant making, a lot of the time key population priorities and programs are allocated to the PAR, so not given proper prioritization. Next recommendation, to monitor investments, and also want to stress the importance of monitoring investments to key population-led organizations, especially as we're considering reaching the Unaids strategy target, global aid strategy target on community-led responses. So the importance of being able to track investments to communities. Fourth, to encourage national decision makers to take a more ambitious position towards PrEP, but also considering community preferences as well, and that there are different targets across the key populations. And also this came up in the discussion during the session a lot, and it was stressed that there needs to be maintaining and sustaining disaggregated data analysis across the different key populations. So next slide. So the second session was reviewing the minimum combination packages to accelerate progress towards global targets. And the recommendations first was to strengthen the role of national AIDS commissions to make sure that there's more coordination across the key population programs, for WHO to hold a consultation process with key stakeholders to be involved in the guideline update of WHO, and to jointly take a convening role in addressing gaps in policy and human rights, and stressing the importance of meaningful involvement of communities in the HIV response as well, and that key population communities and networks would also be, taking a role in the advocacy and convening. Next slide. So there will be a session on this later on as well, but just to put renewed focus on the key population implementation tools, and to work with key population communities and partners in their rollout. So each global key population network, has been doing a lot of work over the last few years. There's various case studies produced on strengthening the capacity of communities on these tools, but definitely, recognizing that there's a gap in knowledge and awareness and capacity of building around these tools and implementing these tools at the program management level and also policy making level. The second last point is to cooperate in the development of evidence country guidance for prioritization, and also want to stress the importance of, communities' role in prioritizing the different HIV interventions as well and packages. And the last recommendation in this session was to ensure balance between cross-cutting principles and approaches. So for example, cross-cutting principles of meaningful community involvement, human rights, including decriminalization. So next slide. So the third session was looking at sustainability with a focus on financial sustainability, the importance of continuing to advocate among policymakers on the importance of HIV prevention and the need to address structural barriers, advocating with governments to continue and enhance HIV prevention service delivery through CSOs, particularly key population-led organizations using domestic funding. But the next two recommendations are about social contracting. And of course, there was lots of discussion around social contracting and domestic budget advocacy not being a panacea and the difficulty of arguing for governments to fund key populations when, many of us are criminalized. So, understanding that, these recommendations need to also be expanded to, to really continue to advocate with multilateral donors and bilateral donors to keep, a skin in the game and to ensure that key population-led responses and funding for social enablers continue to be funded. So next slide. So this is around transition again, but obviously also recognizing the barriers or the problems with expecting that domestic budgets are always going to cover all the elements that are needed with key population programming, to continue to strengthen the UN's brokering role between key population and community-led organizations and governments, and recognizing that this needs to be more standardized across countries as we see real disparities between UN agencies doing this role effectively and in some cases not so effectively. To strengthen data collection, including with developing shadow reports and ensuring that these can be, these are resourced to be done, and also recognizing the role of key population-led networks in developing these shadow reports and needing to be resourced to do so. And lastly, just to avoid setbacks in maintaining HIV-related service delivery during COVID. So next slide and last session was on HIV prevention with adolescent and young key populations. So recommendations here were about the importance of continuing to advocate with policymakers on the importance of HIV prevention with young key populations, and to further explore the role of young key populations in decision-making processes. So next slide. The recommendation around provision of financial resources and capacity building, and also to involve young key populations in data gathering and research as well. So next slide, just a summary of the next steps. Of course, with the view of implementing these action points and addressing these recommendations. Second, to be able to update on the implementation of these action points, and that this would be a standing agenda item in the forthcoming global prevention working groups. And of course, as we're going to discuss further in the global community of practice, to be looking at taking forward these recommendations in our future discussions as well.
Thank you, Judy. I always have the mute issue. So colleagues, as we begin to wrap up the session, I would like to invite Clemens Benedict, who's a senior advisor in the prevention team at Unaids in Geneva, to tell us about the community of practice and what it will do. Clemens, you have 8 minutes.
Thank you. Thank you so much, Paula. I'll try to do it even less. We can go to the next slide, which really just shows again the background that we have heard already. New ambitious targets. We have evidence that key populations are most affected by HIV, accounting for a large proportion of new HIV infections in virtually all regions. We have a global prevention coalition that is moving into a next phase where it will be critical actually to intensify action at country level to accelerate progress. And the communities of practice are really just one avenue for building this momentum together. Next slide. A community of practice, in our understanding, is a group of people who share a concern or a passion for something they do and learn how to do it better as they interact regularly. And as part of this capacity development process, the Global Prevention Coalition, working together with the South to South Learning Network, is establishing this community of practice. Next slide. So the overall goal here is really to build a community of like-minded people across different countries with a common goal around driving key population responses. And it is really about building this unity of purpose across countries, but also within countries, among governments, key population-led communities, and technical partners. And as Shannon has said in the beginning, this is really a big task that we have ahead in achieving these targets, and it takes more than just one organization and one sector. It really requires us to work together. And we have actually some practical examples. We didn't hear from Kenya in this call, but in Kenya, for example, we have seen that a strong government leadership, strong community leadership in some areas, and actually decentralized levels for sex workers as well, for example. And we have strong implementation and programs at scale, and all together, this has formed a strong response in a context that is actually still partially challenging in terms of the legal and policy environment. But there's clearly movement, and we think through this process, we can take such examples in this community of practice and see how we can advance in different countries and different contexts in similar ways as we have seen in those countries that have recorded successes. We want also build accountability, peer accountability for progress, and discuss with each other on how we're doing in actually progressing against global AIDS strategy targets, and contribute to strengthening country capacity and improved programming. The next slide just shows the same again in some outcome language. So what should be the outcomes at the end of this community of practice, which we hope to maintain at least for the duration of the next prevention coalition, which is 3 years. Enhanced evidence-based key population-led programming in the participating countries, strengthen peer accountability and joint problem solving, enhanced feeling of being part of a global community, working together across sectors as mentioned, and again, the capacity in relation to design and implementing key population programs and responses in the broadest sense, including the structural dimension. Next slide. So just for your background, where does this fit overall in terms of global prevention coalition communities of practice? There's one on HIV prevention response management currently among 28 countries with NAC managers participating. There's one on condom programming, and this one is the third one that we're actually launching. And the other communities of practice are still in preparation, also looking at how we can work together with existing groups. Next slide. So what is the audience and the participation of these communities of practice? So this is different from global working groups, as you have realized from the participation in this call. It's really a country audience that we want to engage with and to engage with each other. And that includes national government program leads, whether it's in NACs or in ministries of health. It includes national key population-led organizations. linking to the global networks, but also in-country networks and associations and implementers that are key population-led. Country-level implementers from other constituencies, Global Fund and PEPFAR recipients and implementers, other civil society implementers, and then technical partners at global, regional, and country level joining as well, and thereby making, you know, what sometimes may be known in a project or in a specific initiative known to support a whole national program on key populations and strengthening a national response. Next slide. So how will it work practically? There will be online events hosted by the GPC Secretariat, working with the South-to-South Learning Network. And each meeting or each session will have a technical focus area, a session sharing a country experience, and then also a session sharing key population community-led experience. Sessions will include different types of engagement, presentations, films, videos, and country case studies, really a mixed method approach. And in languages, we'll try to stick to what we have today in terms of English +4 simultaneous translation languages, French, Spanish, Russian, and Portuguese. Next slide. Resources for the community of practice can be found under the HIV Prevention Coalition website. You go to resources there and then select key populations, and you will find all the documents that we are talking about, including implementation tools and others, and that will be shared later on this resource. Next slide. So what are the next steps? Encourage other colleagues to register. We reached out widely, but we may not have received all the relevant contacts and email addresses, and we'll provide our contacts again in the end, which you had in the invite. We'll provide them at the end again for you to contact us. Contribute success stories for sharing. If you have strong national programs to contribute to sharing to other countries, please let us know, and we'll try to include them as part of the community of practice sharing, and propose additional topics for sessions and newsletters, and we'll show you at the end what actually the plans are for the 4 sessions where we already have identified topics. So with that, I think I'll hand back over to Paula, and yeah, to the numerous areas that we have actually already seen being raised in the chat. So over to you, Paula and Carrie, for the next section.
Thank you, Clemens. Thank you, colleagues. We are coming to the end of our introductory hour. This really has been a great introductory call. We had close to 200 participants, so thank you very much for devoting the time. As Clemens has said, in the next steps, the community of practice is going to be as good as the activity of the members. So this is the beginning of a long relationship. Please keep this living, contribute your questions and gaps, things that you would like to see highlighted, and contribute your success stories and contribute your learning, because other members of the community can learn from challenges and successes, including failures. So there are a few open questions in the chat, but I'm very pleased to see that Keith and colleagues have answered many of these in real time. Carrie, do you see any questions spotlighted that we might invite comment on before we have to close?
Thank you, Paula. Perhaps I can just flag some of the key points that I'm not sure if a panelist would want to comment on it, but just something that's coming up as key themes. I think many of the comments relate to the importance of community-led prevention. There have also been a number of questions around data. So that's including what the global targets are, what the tiers of risk might be and the definitions around that, the importance of size estimates and some of the gaps and challenges that exist around that. And I think that's just something for reflection on the community of practice, perhaps as we move forward. There have been a few questions around some of the wording and the way that some of the information has been detailed and disaggregated, and I suppose that's just for ourselves to consider as we continue the community of practice. And then there was some questions just around the definition of key populations and which groups those include in this community of practice. I'm not sure if someone from one of the panelists would like to talk about those, but I think that's how we could group the Q&A. Many of them have been discussed in the Q&A, and perhaps as the last few presentations are taking place after this, if there's any outstanding questions, maybe we could also just ask the panelists if they would kindly respond in the written space.
So I'd like to say that we should respond to most of these in writing, but very briefly, Clemens, how often will the follow-up sessions be organized?
Thank you, Paula. Yes, so we will have follow-up sessions in this year, and we have a minimum of 4 of them scheduled. And I think Lulama will introduce the topics after this discussion section when we discuss the future sessions. So we plan to have 4 additional sessions, but there is room to actually add additional topics. For example, we could have a special session on harm reduction or on any other topic that is being proposed.
Okay, Kerry, I need your guidance given the time now. What would you like to do next? Shall we just keep going with the tools and resources for the COP and the next steps?
Paula, I think we can do that. Perhaps what I could just say though is that we are documenting all the questions, and obviously this is just an introductory session. So we can try and respond to some of the questions in writing when we circulate the presentation. And of course the follow-on sessions are really where there will be much more interaction, I believe.
Okay, great. So could we move on then to some of these questions might be answered by looking at the tools and other resources for the community of practice. Could we ask Virginia, please? Virginia is a colleague from a WHO prevention team to talk to us about some of the tools and other resources for the community of practice that are available. And Virginia will be followed by Navon O'Connor, Communications Manager at GATE.
Okay, thank you. Thanks, Paula. Thanks everyone for having me here. I'm really happy to hear about this communities of practice. It's so important, and glad to be part of this. And I'm also glad for the opportunity to introduce a little bit about our update of the WHO Key Population Guidelines. I am presenting at this session, and my colleague Annette will be presenting this afternoon. Okay, next slide, please. So hopefully most are aware that WHO developed the Consolidated Key Population Guidelines in 2014, and these were updated in 2006.
Virginia, I think we might have lost you. Have we lost Virginia?
It seems to be.
Can we move into Navon and come back to Virginia? Virginia, maybe if you log off and log on again.
Thanks. So I guess I'll proceed from here and then we'll go back to Virginia. So thanks, Paula. So yes, I'm going to be giving a brief overview of the key population implementation tools. And these focus on centering key population communities in the global HIV response. So next slide, please. So the key population implementation tools, trying to get my mouth around that word, were developed and produced collaboratively between WHO, UNODC, UNFPA, and Unaids. And this was done alongside key population networks, including NPACT, NSWP, IRGT, GATE, and INPUD. And this was also done in consultation with other technical partners, academics, and with individual community members. So the purpose of these implementation tools is to translate the HIV guidelines into practical how-to guidance that key populations can use in support of advocating for and implementing high-quality key population programming. So each has been targeted to specific key populations to ensure that the guidelines are relevant for each community. So for gay and bisexual men, for sex workers, for trans people, and for people who use drugs. And obviously the key strength of these tools is that they make the HIV guidance not only accessible, but applicable to the quite often oppressive situations and issues that key populations faced. And these are based on the in-depth knowledge and understanding that these key population networks have of our communities. So next slide, please. So what sets these apart? The implementation tools are an important resource as they center community empowerment and the meaningful involvement of key populations in the global HIV response. So there are several interrelated parts across all of these documents. So across all of the tools, the necessity for and importance of health access and equity for all key population communities is highlighted and heavily emphasized. In the first chapter of each implementation tools, then the critical importance of community leadership and empowerment is highlighted. And this focuses on the necessity of centering the roles of key population communities and their meaningful involvement in the HIV response at all levels. So each of these tools also provides context for the social and structural marginalization of key populations that impacts their engagement and inclusion in the HIV response. And some of these issues include stigma, discrimination and violence, criminal and punitive laws and policies, and economic conditions, which often include enforced poverty as a result of such laws, as well as sociocultural situations. And all of these tools then provide interventions that are specific to each key population community. And these include actions relating to HIV prevention and treatment, harm reduction, social protection, community mobilization, and advocacy. So next slide, please. So how can you access and use these tools? So copies of these implementation tools are available from each of the key population networks. And you can see them listed there on the screen, including NPACT, NSWP, IRGT, GATE, and INPUD. And we strongly encourage you to reach out to each of our networks, to get a copy of the implementation tools. And we're also encouraging you to get in touch with us if you would like to receive some technical assistance on how to use them if that's needed. And I believe that attendees will receive a copy of these slides after the presentation. So hopefully you can use the information on the slides to find our websites and contact information once you've received them. So that's it for me, thanks.
Thank you, Nibon. Could we look back to Virginia? Virginia has rejoined us. Virginia, please, your presentation on some of the tools and resources that are available to programs, networks, government programs.
Yeah, really sorry. I hope I managed to make it through the presentation. I think we can go to the next slide. So this is just, again, a reminder of the comprehensive package of services recommended in 2014 and again in 2016. You probably know all of these: HIV prevention, harm reduction, HIV testing, treatment and care, prevention and management of co-infections and comorbidities, and sexual reproductive health interventions. But really importantly were the 5 structural interventions listed here. And the guidelines also have recommendations related to service delivery. This is the current guidelines that I'm talking about. Okay, next slide. Yep, we all know well the 5 key populations. I just want to make the point that the previous 2014-16 guidelines were very much focused on HIV. But our new updated guidelines will also include recommendations related to hepatitis and STIs. And for some key populations also TB. And this is because all of these structural barriers are barriers not just to HIV services, but to broader health services, including hepatitis and STIs. And many of the interventions that we would recommend for HIV prevention can also prevent hepatitis and STIs. So for that reason, the new guidelines, which we're currently updating, will also include hepatitis and STIs. Next slide, please. The issues to be addressed in our guideline update. So we know that the uptake of the comprehensive package of interventions is low, but it's improving. And certainly updating our guidelines is another opportunity to promote the guidelines. As I said, we're changing the focus to include hepatitis and STIs. There's various new recommendations from WHO that have happened since 2016, including new hepatitis recommendations, STI. Just recently, WHO launched new HIV treatment recommendations, testing, and of course, there's been new PrEP recommendations and new ones expected in the next 1 year. The other important difference is that we will have modules presented by population rather than having a comprehensive package for all populations, and we will prioritize certain health interventions for each of those populations. And it's probably an omission should be on this slide that the structural interventions or enabling interventions will remain prioritized in every setting. Okay, next slide, thanks. And just we're updating and developing some new recommendations, and just to give a bit of information about what they relate to. So we're expecting updated recommendations on behavioural interventions, a new recommendation around chemsex and behavioural interventions to reduce the risks associated with chemsex, new recommendations about using virtual platforms for outreach, case management and targeted information, and new recommendations about peer navigation. And then also for hepatitis C, a new recommendation about testing and treatment for people with ongoing risk, which is principally people who inject drugs in this context, and pooling samples from 3 anatomical sites for STI screening, principally about MSM in this context. Next slide, please. And we're really grateful for the work that the 4 global networks of key populations are conducting. They're doing qualitative research to assist with the guideline development, and they'll be investigating the values and preferences of their community members related to the new and updated recommendations, their health priorities, service delivery, and structural barriers. So that's a really key part of our guidelines development, and all 4 of the global networks will be represented on our guidelines development group. So some key dates: the guidelines development group meeting will be held from the 31st of August to the 8th of September. Not every single one of those days, just some afternoons. And we expect to launch the guidelines with an app and a web page in the first quarter of 2022. Next slide. These are just, that's what the 2016 guidelines look like, and there's a link. And also when those guidelines were developed, there were 4 technical briefs developed alongside them related to young people who were members of key populations. And there was also a tool to set and monitor targets for key populations, which was developed at the same time. So all those documents are kind of a set. Next slide. And when you get the this copy of this presentation, you'll see these are hyperlinks to various WHO guidelines which are relevant, including those related to HIV testing, treatment, strategic information, PrEP, and I've also included links here to guidelines about hepatitis and STIs and TB. Next slide. And also just, these are also hyperlinks to really useful other sites. Of course, the Unaids Key Population Atlas, which provides country, national and subnational data on key populations all in one site, is a great resource. The Global Prevention Coalition website has, you can select key populations and you can see various publications related to key populations. But to highlight, currently it's important, the strategic considerations for mitigating the impact of COVID-19 and the considerations in planning and budgeting for key population trusted access platforms. There's Global Fund information notes, which are quite useful, and also FHI 360 linkages has great tools, particularly for people wanting to plan reaching and providing case management services to key populations online. And I think that is the last slide. Again, I'm really sorry I dropped off before, but thanks for giving me the opportunity to speak to you today. Okay, thank you.
Thanks, Virginia. I'm glad you made it back. It's really good to see that we've already got a wealth of tools and resources, and a good number of them are being updated in the near future. So please do make use of this. And it sounds as though the community of practice is up to a, is up to a flying start. To share some of the future plans for this community, may I invite Lulama from the South to South Learning Network. Please come in.
Thanks, Paula. Good morning and good evening, colleagues, depending on where you are in the world. My name is Lulama Lunika from the South South Learning Network. Today, I'd like to share with you what's coming up next in the community of practice, or what to expect next going forward. Next slide, please. These are the following topics that have been identified for future webinars. As you can see, we'd like to explore kind of what it takes to build a strong foundation for scaling up impactful programs with key populations. And we'd like to look at how to address structural barriers to scale up access to services among key populations, and how to measure and monitor key population program outputs at national and global level. And finally, we'd like to explore how to finance and sustain key population programs within countries' HIV response. These are draft and proposed topics, and they're very much still open for feedback from the members on this call today. So please let us know if you have a topic in mind, or if you feel we haven't fully covered everything, and we're more than happy to revise this list of topics or add new ones. Next slide, please. You can also expect a quarterly newsletter to come your way, which will share news, publications, and events planned related to the key population programs. We hope that this newsletter will help improve access of community of practice members to new tools, trainings, and sessions that will help improve programming with key populations. The themes of the newsletters will be similar to the themes of these virtual meetings, and any new GPC related publications will also be shared. Would like to open up the floor to you to, if you have any documents such as, any documented best practice, guidelines or case studies, or anything else that you'd like to share with this community of practice, please share these with us and we'll ensure that they're accessible to the rest of the community. The SASA Learning Network has been identified to support this community of practice administratively. So please feel free to email us. I've provided my email at the bottom of the screen, should you want to share any documents with us to share with the wider community. Thank you for your time.
Okay, thank you very much, Lulama. I'm hoping that although brief, that was clear, at least for the initial phase, what the contacts are, where and how we can start to share experiences, information, and resources. And quite soon, we ought to be able to communicate the date of the next session. And as Clemens has said, we are hoping that the network can fit in 3 to 4 sessions between now and the end of the year. So that is a frequency of roughly every other month. If you've got any suggestions regarding sessions to highlight that you feel are not covered by the suggested themes from the South to South Learning Network, again, please do feel free to reach out to us. And thank you, Kerry, for screening this slide, which gives the 3 basic contact persons. We have 10 minutes left, and there is a question from Anton that you feel has not been responded to. Anton, are you able to come in and ask your question, or can somebody please read it out so that a panelist can address it?
Yeah, hello.
Okay, Anton, please go ahead. I'll give you the floor.
Yeah, so my apologies. Yeah, Anton Basenko, International Network of People Who Use Drugs. I'm based in Ukraine and drug user and harm reduction activist. So yeah, sorry if I missed some of those points somewhere in the beginning because I jumped from another call. But on the slide with the planned areas of community of practice, there is clearly stated things like male circumcision, condoms, like KP, prevention among KPs, but I don't see there the harm reduction, opioid agonist therapy. So I'm just wondering why it is not. So what's the logic of such differentiation? I understand that it could be possibly hidden somewhere inside prevention among key population, but since you take some interventions like male circumcision or condoms or PrEP in separate areas, why the harm reduction or OET is not there as a separate areas? Because we all understand that for particular regions or even globally, the prevention agenda of people who inject drugs and prevention within the injection drug scene and such critical life-saving interventions like harm reduction, needle syringe programs, OET, and naloxone, and blah blah blah. It's everything should be there. I think it's even have to be there. So what's maybe the logic of such differentiation?
Thank you, Anton. Clemens, do you want to take that, please?
Thank you, Anton. Yes, a great question, actually, that was discussed years ago when the Prevention Coalition was designed. So first of all, that slide that I presented there was referring to other communities of practice. So these communities of practice we had there in terms of male circumcision and PrEP and young women go beyond the key population and community of practice. So clearly within this key population community of practice, harm reduction is a very important issue, and we could even dedicate a separate dedicated session to it. Why it happened that way, maybe just very briefly, since condoms, VMNC and PrEP actually extend to different populations, they were made and are cross-cutting for different populations. They were made separate pillars, since harm reduction would primarily be among key populations and people who use or inject drugs. It was actually looped into the key populations, pillar of prevention. But this is a discussion that could be held again when the new prevention roadmap 2025 is being developed on what the pros and cons are for this decision. Certainly, we want harm reduction to have very high visibility, and that would obviously be greater in a separate pillar. On the other hand, it takes it out of the key populations pillar where it is really focused mostly. So I think that's a discussion to have in this next phase of the Prevention Coalition on how to present this best. Thank you.
Great. Ruth, I hear you've joined us now. Is that so? Ruth Masha?
Hi, Dr. Ruth Masha is represented. She's held up in another meeting. She had indicated she'll join us if possible. If not, she'll join us in a later meeting. Thank you.
Okay, I just thought I saw a text message that Ruth had joined, and I wanted to invite her to talk about the country perspective. Anyway, let me just take this time to ask if there's anyone who feels that their question has not been addressed either in chat or in the Q&A box. And I would just like to invite you to put up your hand quickly for a key comment.
Just a key comment from, this is Carol representing Dr. Ruth from Kenya. From the key populations presentation, I also did not see the inclusion of transgender. I don't know whether that is an area that we can consider. In Kenya, we have prioritized them as a key population, and they are part of the prevention programs that we are having that are targeting the key populations, especially in terms of stigma and discrimination. They find themselves very stigmatized and discriminated. And therefore, as a country, we have indicated that they are also part of the key populations. I don't know whether this can also consider inclusion of the same.
Thank you, Carol. My take back from this is we clearly need to communicate way better on what is included in that blanket term of key populations, and maybe, and this is a personal quirk, maybe use key populations less, but rather actually name the vulnerable and priority populations that we are referring to for reasons of clarity. But Ruth, I see your hand up. I'd like to give you the floor because especially if you want to comment on this last question.
Yeah, no, I would, Paula. And I think it's really important that we do name the key populations. The evidence that we have points to 5 particular populations that are hugely impacted by HIV and who we are not managing to address the epidemics amongst. We're not meeting the targets globally, but for these populations, we're particularly failing them. And I think that all of them need to be specified. All of the key populations have very particular needs that need to be addressed that are quite specific. So I agree we should be calling out the names, but I also don't think we should be expanding the key populations beyond those that we already have. They have been clearly identified by epidemiological evidence and testing around the world as being those that are most vulnerable to HIV. So, and I hear the calls around transgender. I think the important thing for me is that we do not just blinker ourselves and only focus on trans women, which is a lot where the data comes from, but we also need to look at trans men. It may be less risk, but there are still above the normal levels in the remaining population for HIV prevalence. So I think we can't afford to miss anyone, and we can't afford to ignore any of the interventions, including harm reduction, OST for people who inject drugs. We need a really comprehensive response to the key populations if we're going to succeed together. Thank you.
Thank you, Ruth. Navon, is that a new hand or an old hand?
It's a new hand. I just wanted to add it to add to Ruth's comment. You know that GATE is working on increasing the inclusion of trans people in the HIV response, and as what Ruth mentioned as well, the inclusion of trans men in the HIV response. And we do have trans men and HIV working group who are trying to increase the data and research and the inclusion of trans men in this research. But also just in general, the inclusion of trans people as a community. So if people do want to get some more information on that, I encourage you to contact GATE, and we can certainly point you in the right direction. Thanks.
You want to say what GATE is, in case we are confusing you with a bigger GATE, or the GATE that everybody thinks about?
Yeah, we're not the GATE Foundation. We are GATE Global Action for Trans Equality. So it's gate.ngo online.
Thank you.
Yeah.
Really, I think Ruth and Navon have given the closure for this, given the closing comments for this session. We are still over 150 on this webinar. Thank you so very much for spending the time with us, for showing your interest by showing up for this introductory call. We don't take your time for granted, and we really look forward to meeting again frequently and to learning together and sharing between now and the end of the year. So thank you very much for your time. Have a good day, good evening, good afternoon, wherever you are. And I guess we'll leave this there until the next time.
Thank you very much, Paula. Just to indicate that Dr. Ruth Masha is in the call, but she's unable to speak because of her mic. Sorry about that.
Thanks, Carol. Thank you. We're sorry about that too.